Good afternoon, and welcome to the inaugural Vito Imbasciani and George DiSalvo LGBTQ Health Equity Lecture Series. We have the great pleasure of hosting not only Dr. Imbasciani, but also his spouse, Dr. George DiSalvo. So we have with us not only our first lecturer in this endowed lecture series, but the people whose generosity have endowed the series so that it will become a permanent fixture in our College of Medicine and our university. The lectureship is aimed to ensure the preparation of culturally competent physicians who can provide medical care and prevention services that are specific to LGBTQ populations, something that is long needed, special attention in our medical school and those across the nation. To the best of our knowledge, this is the first such lecture series at a medical school in the United States. Now, we certainly hope that that doesn't continue to be the case, and so we're really pleased today to welcome guests from the Gay, Gender, and Sexuality Alliances at several other universities. We have representatives from Brown, UConn, Harvard, and Yale today, and I want to thank you all for making the trip in difficult weather situations. I can tell you that Vito and George had a 36-hour epic journey from California to Vermont the other day. Vito and George are immersed in the healthcare field. George has spent 25 years in healthcare delivery, including currently serving as the Chief Financial Officer for Southern California Kaiser Permanente. He holds both a bachelor's degree and an MBA degree from University of Southern California's Marshall School of Business. Vito has a long history and deep connection with the College of Medicine that began in the early 1980s when he entered as a member of the class of 1985. He was not your everyday average entering student at a medical school. He already had a master's and a PhD from Cornell, had been a Fulbright scholar, and was serving as a professor of music history at Middlebury College. However, his deep interest in medicine, combined with his enormous energy and his obvious, from many things, his obvious willing to take a chance and just go do things, led him to switch careers, which was just not the thing people did in that era and time. And it's a decision we and thousands of patients across the country and really across the globe are grateful for. Today, Dr. Imbasciani is a urologic surgeon based in Los Angeles and is the Chief Medical Officer of the California National Guard. He's been a member of the Medical Corps of the U.S. Army for 28 years and is a veteran of both the Afghanistan and Iraq wars. He served a total of 4 active duty tours there. His medical service in the Army is an outstanding example for all of us, but it has also been a touchstone for the experienced gay and lesbian professionals, indeed all such soldiers have faced. Despite his years of service, Dr. Imbasciani was unable to discuss or acknowledge his status as a gay man throughout most of his military career. And George and their children were unable to send him off on his deployments, nor were they able to be there with the other cheering families when he returned from the battlefield. This was a shameful chapter in our nation's history. The years of Don't Ask, Don't Tell ended in 2011, and about this period in our history, Dr. Imbasciani spoke beautifully in his introduction to President Obama in Los Angeles a couple of years ago, and we were playing the tape of that introduction as you were filing in. Vito is a gifted physician. He has a vast experience in life, in medicine, on the battlefield, and in the home front. Please join me in welcoming an outstanding member of our class of 1985, Dr. Vito Imbasciani.
Thank you, everyone. You can hear me? George, can you hear me? You never listen to me. Dean Warren, thank you. That was a very, very gracious introduction. A lot of thank yous before I get started. This is really wonderful. Meredith, are you there? There you are. Meredith Armitage and other members of the Alumni and Development Offices for the invitation of this to be here with you today. And to the medical students here at UVM and to their invited guests of all the gay and lesbian and students from the other medical schools in New England, welcome. The entire community, including some of my classmates from the class of 1985 who had the ability to walk here today. And speaking of that, I know the first year students had a session I was part of on falls. You did not mention snow and ice as a precipitating factor. Add that down because I had difficulties this morning. And a special thank you to, maybe some of you don't know, Dr. Don Evans can't be with us today. He's down in Westport, Connecticut, UVM class of 1962, whose presentation here last year was the genesis for this lecture series. It is absolutely wonderful to be back in Vermont. You have so much water here. And it's so white, but getting less so every year. Not talking about the weather. It's hard to take in. 30 years ago, I wasn't sitting in this classroom, but I was upstairs in Hall A. And as an eager medical student and a closeted gay man, I had just successfully made the transition from the Q in LGBTQ to the G. But nobody knew it, not my family, not my friends, not my classmates, and not my roommates. Now, 30 years later, I'm standing, not sitting, and I'm in front of the class. This is what's happening across the nation. In the increasingly in the closeted worlds of Hollywood, where I live, in the military, in politics, and now even in professional sports, individuals are finding the freedom and the necessity to come forward and speak out about who they really are. It would seem that, and I mentioned this jokingly to some of the students yesterday, the love that once dare not speak its name is now the love that can't keep its mouth shut. I studied medicine here at UVM from 1981 to 1985, when tuition was $5,000 a year. We can talk. I have solutions. Which means I received my MD degree, and this really gives me pause, before most of you were born. And that, unfortunately, makes me a historian of my own life. And that means that you will perceive everything I say through the lens of history, and I know what that effect is. Because like other major events, the Holocaust, Hiroshima, the Kennedy assassination, the lunar landing, maybe even 9/11, this all happened before you. And the consequences, it didn't happen in your life, and you don't have that, maybe the specific knowledge of those events, the details, the minutiae that go into it, and you don't have the emotional investment in it, unless it's impacting your life, as it does in some of you here, compared to your elders. Walking into Hall A every day, I looked around me, and all I saw were straight men and women, and almost all of them white. And except for one of my female classmates who was bravely going about her life as an open lesbian, for all 4 of my years here, I was convinced, and I'm still convinced, that I was the only one. I was the only gay man. One of my class of 85 classmates came out 15 years after we graduated. But I was alone. And I wondered, there were no gay students? Is that possible? There were no gay faculty? No one in the administration? There was one dean I wondered about, but today I think we would just call him a metrosexual. So I wondered, am I that different and am I the only one? UVM lacked diversity in other areas too. The College of Medicine was very good at reflecting Vermont's monochromatic demography. I once asked Dean David Tormey, dear friend of happy memory, why all the students in the medical school were Caucasian. And his answer was that they had very assiduously tried to recruit students of color and others, but when prospective students got off the plane here and at the university, they were shown the love, But then they sat back after the interviews were over and wondered, but my God, at 5 o'clock, what am I going to do? Where's my community? No one here to support you. I knew what that felt like. The only reference to the LGBT community in our entire 4-year curriculum came on one afternoon in February of 1983, right in the middle of Human Sexuality Week. How coincidental. We spent an entire afternoon, all the second-year students, watching educational videos designed to enlighten the uninitiated by frankly depicting all the permutations of human sexual congress, straight, gay, and geriatric. Nothing high school students can't discover by themselves online these days. Trust me, I've got a 13 and a 15-year-old at home. How simple that all seems now in retrospect. Back then, if you weren't straight, you were either gay or lesbian. Now we have to acknowledge a much larger universe, including LGBT, gender nonconforming, and persons with differences of sexual development. You have to realize that to treat patients successfully with the dignity and respect they deserve, it behooves you, all of us, to recognize and treat appropriately those with differences in gender identity, gender expression, and sexual development. And the vocabulary is confusing. Transgendered, transsexual, transvestite, bisexual. And what about the older categories, the ones that I learned? Do we still have hermaphroditism? How do you think about or talk about the ambiguous genitalia of those with all those adrenal syndromes that were the bane of my oral exams for my boards? And what about those little oddities like the guavadoses, boys that are born without testosterone receptors and who have everyone in their community completely fooled until puberty? We recognize today chromosomal sex does not determine phenotypic sex, and neither predicts to what gender you will be attracted to. Even I get confused when presented with a transgendered woman who's attracted sexually to a straight male. What's going on? I have to stop and go down the paradigms. Watching those films back in February 1983 was, for some, like learning a few new words in a new language. While necessary, not sufficient to have a substantive conversation. And in 1983, there was no conversation on what it's like to be in a sexual minority, how to apply for a residency spot if you are openly gay, how to find a position after residency, what kind of a practice setting would you be in, solo or group, what if my partners find out, what part of the country should I go to, what cities should I avoid, are there any specialties closed to me? Think about it, gay man becoming a pediatrician. Think about it. Difficult choice. And that was before the Catholic Church. I remind you, and so these were the questions I was desperate to have answers to. Instead, all I got that afternoon was a tutorial on the mechanics of sex, and it was in the context of disease transmission. Because 1 month after the class of 1985 got here in 1981, the monthly or weekly, I forget, the morbidity and mortality reports coming from the CDC started referencing this strange new sexually transmitted disease that was initially called GRID, G-R-I-D, gay-related immune disorder, subsequently renamed AIDS. 1980s were a terrible time to discover you're gay and try to have a social life. There were no undergraduate student alliances of gay students and their friends. And sometimes when I use gay, I'm shortcutting the entire LGBTQ community. And for their supporters, there were I think there was only one gay bar in the entire state of Vermont. And that was a very dark and desolate place at the top of Church Street. Not there anymore, thank God. So, moving on to residency, more turbulent times. Assumptions were made about me by fellow residents based on my choice of who I lived with as a housemate. a gay resident in ear, nose, and throat surgery. And that acknowledgement engendered rather overt hostility toward me by fellow residents in my own department of urology, throughout the surgical ranks, and even among students from Yale rotating through the services and attendings. Homophobia was rampant at the time, and it was exacerbated by the widening AIDS epidemic. The first autopsy at Yale New Haven Hospital on a patient who succumbed to AIDS was on a resident physician in radiology. And an OBGYN professor, a very proud African-American man, who was much beloved by the students, he died completely alone at home from AIDS because at the time to broadcast his diagnosis and seek medical care would have meant simultaneously broadcasting his sexual orientation. I recall one Saturday morning, grand rounds in surgery, and to the Yale students, by the way, this is, if you're here, I love the institution, there were problems, and this is certainly not a reflection on the way things were. This is history. A neurosurgeon started general grand rounds one Saturday morning with a joke. He asked us if, this is all the faculty, the community, New Haven, all the residents, had we heard about the new AIDS diet at the hospital? Pizza. It was the only food you could slide under the patient's door. Because across the country, not funny, huh? Across the country, medical care providers were starting out of fear and ignorance, and we're seeing the exact same thing with Ebola now. Fear and ignorance in the early phases of an epidemic engender behaviors that are far from noble. And people were refusing initially in 81, 82, this is now 85, 6, 7, to treat AIDS patients until the chief of staff of the hospital threatened to fire anyone, attending, doctor, medical student, resident, if you did not treat AIDS patients like you treated all the others. Sometimes, in times of stress, even good people need to be goaded back to their Hippocratic ideals. So in this environment, I took a gamble and complained about my treatment to the dean and chief of surgery, who were both aghast. One out of a genuine recognition of the harm being done to me personally, and the other, frankly, out of a fear that I was going to embarrass the university by calling a press conference. Lesson learned, fight back. Can't hurt, might help. I didn't tell the truth here in medical school. I didn't tell the Army the truth either when I signed up. I didn't overtly lie. I just neglected conveniently not to fill in the one bubble out of pages and pages of bubbles that asked, "Are you a homosexual?" And that led me to a parallel career that the dean quite nicely referenced. As a medical corps officer in the United States Army, Army never paid for a single day of my education. My service for 28 years was completely voluntary. Could have quit at any point, and that's through 4 deployments and 2 wars. Under Don't Ask, Don't Tell. I persevered partly because military service is a proud tradition in my family, and partly because I absolutely loved being a war surgeon. I have time for a little war story. My commitment to the medical corps and treating, even regardless of my personal feelings toward war, taking care of American young men and women when they're sent into harm's way is a noble cause. 5 days after finishing my residency at Yale, I was at King Abdulaziz Hospital in Dhahran, Saudi Arabia. I was the urologist. And this hospital is quite something. Marble, glass chandeliers, Persian carpets in front of every bed so the patients, if they could pray to Mecca. The hospital was completely empty. We sent all the patients home, and the entire hospital staff went down 7 miles away to Khobar Towers. I was alone, 9 o'clock, February 23rd, the night of the last Scud missile attack by Saddam Hussein against our forces. Me and 4 Army medics, Army staff sergeants, in the entire hospital. And we're watching Al Jazeera when the screen goes blue. And that was the code that our AWACS planes detected a missile launch, a Scud missile launch against Kuwait or Saudi Arabia. By the time the screen turned yellow, which meant it was coming at us, we were already running down to the safe room to put our gas mask on, and then the screen went red, which meant you had better be there. I had a panic because I couldn't get my gas mask to seal. One of the soldiers reached over and found a loose strap, and fine. 2 minutes later, the earth shook like a 5.7 earthquake if you're from California. and not this kind, but the bump, kind. And everything was very, very eerily quiet. And I walked out with the other soldiers, and after about 2 minutes of quiet, we heard ambulance sirens, and then the ambulances started arriving at our hospital. We were only 1 mile from the blast site. The Patriot missile had knocked the Scud out of the sky, unfortunately fell straight down into a building that had housed an entire unit of reserve soldiers from Pennsylvania who had just arrived that day. And the ambulances started coming first singly and then in droves. And it's just me and 4 medics. And first they brought the dead, and then they brought the wounded, and then the walking wounded followed. And the dead were so numerous, I didn't even know they were all Americans at first, or that the first 2 were female, because they were all coked with this black soot. Like in those Keystone Cop movies where the pie explodes in your face, you had to dust them off, and you saw the American flag. So I converted the mosque and the hospital to a temporary morgue and put all the soldiers in there. And then, by then, an hour later, the reinforcements arrived. The rest of the hospital got the 7 miles over to us. We opened up the operating rooms, worked all night. I worked to save a young sergeant's life till 7 in the morning who had bilateral hematoneumothoraces. George, that's collapsed lungs and, and a cut ulnar nerve. And so the point of that story is one surgeon, in the space of 1 hour, given that only 136 soldiers, American soldiers, died of combat-related injuries in that entire war, I pronounced fully 1/4 of all the American dead in an entire American war in 1 hour. And the Army loved me ever since. They just didn't know who I was. I obeyed the don't ask, don't tell law because it was the law of the land. Army never knew about George's existence or that we had adopted 2 wonderful boys of Mexican-American descent born in California. But I worked behind the scenes because I couldn't come out. In the history of the United States, we are the first group of people who are not allowed to self-identify themselves to have a redress of grievances before Congress. Everybody in history in America took to the streets. Right? Civil rights, women's suffragettes. But if you came out, Anderson Cooper asked me to be on his show. I said, I'd love to. I'd love to be the Rosa Parks of this. But it would out me, and I'd either get court-martialed or administratively separated, and that would be a rather ignominious end to my lustrous, at least up to that point, career. But I worked behind the scenes by talking to congressional staff and Pentagon staff to let them know the human cost of the lie that they forced many of their soldiers to live. And that's why President Obama thanked me. Things are so much more complicated now than in 1983, but I like it this way. I practice in one of the most complicated environments in the nation. I chose California over New England because of its cultural diversity and because it gave me the personal space and freedom to practice as a gay physician. I live in a county of 10 million people, the size of the state of California. 84 languages are spoken in our schools, in our courts. I won't describe our ballot. I ran for the California State Senate from a small little district in Beverly Hills, Hollywood, and some of the beach communities. 960,000 people in my little district. And I know California's only got 650, so. Besides our county medical society, of which I will be president next year, there are 54 ethnic medical societies in Los Angeles County with tens of thousands of doctors who go to the Armenian, the Korean, the Russian, the Japanese, the Vietnamese society to have native food, kibitz with their colleagues in the motherland tongue, and maybe marry their sons and daughters off with it. I joined the Kaiser Permanente because it reflects the community it serves. We are the most culturally and racially and ethnically diverse medical group in the country. A few side remarks about Kaiser Permanente. This is not a pitch, but I just want to describe something about how radically different it is from what I thought I would be doing when I came here. I thought I was going to go back down to Middlebury and be a family practice doc, and then urology attracted, and But we are an extraordinarily large enterprise. Kaiser Permanente Health Plan and Medical Group is the second largest employer and landowner in the entire state of California. And my husband George up there, we got married last year after 10 years of being domestic partners. He's the CFO. He oversees a budget that if KP were if it were a for-profit entity, it would be listed in the Fortune 500 list as number 47? All right. It's a huge undertaking. He oversees a budget, I don't know, of $26 billion. We serve 7.5 million members in California. 1 out of every 5 citizens in the state belongs to us. I sat on our board of directors for 10 years helping to run the business from the physician point of view. One aspect was the budget. Our payroll alone was $356 million every other Friday. To implement the cost of the most highly evolved IT electronic medical record with absolute complete connectivity and transparency, drugs, not mental health, drugs, ER visits, CAT scans, every other provider's notes. We have spent $4 billion. So when your local hospital is trying to scrape together the $26 million, good luck. But we can talk about the practice of medicine later. I realize that some of these statistics actually might scare some of you. It sounds vast, impersonal, corporate, but I can assure you it's anything but. Every patient in California, all 7 million of them, have their own physician that they can see regularly, they're bonded with, may even speak the same language, because we incentivize our physicians to learn languages. I speak 7 that I can not use an interpreter for. I certainly wish I spoke 14 more, mostly Asian languages. I think I'm just too old to start learning Mandarin and Korean, but I know 7. You can email your physicians. I'm in contact with lots of people who are fretting over their PSAs just by texting. Patients have ongoing relationships with their medical and surgical specialists. Anyone I've ever operated in the last 25 years, still alive from either kidney, prostate, bladder, testicle cancer, is still my patient. They don't go back. I keep them. The nicest thing is that it's enabled me to practice the most scrupulous medicine possible. I never once, in 25 years, you can spend 35 years with us, never once have to pick up the phone and call the health plan to ask permission for a test, a CAT scan, or a procedure. In our charter, the entity, the doctors belong to Permanente, the health plan runs the hospitals. The charter says the physician is the sole determinant of medical care. That's the way it's supposed to be. Let's go back to the topic at hand. Our doctors in our medical group speak all the languages of the community. Our patients in all the little Chinatown, Thai town, right, little Armenia, whatever, can seek out doctors who speak their language. We have physicians who are fluent natively, or will incentivize them to buff their language skills. If they're fluent, we need them in Korean, Mandarin, Tagalog, Farsi, Armenian, just to name a few. In my department of urology, we are 7 men and 1 woman. We represent 5 religions. We've got a Peruvian, 2 Iranians, 2 Indians, and me. One's a woman, Chinese American, and 2 of us are gay. Our entire medical group has its own pride group. Thinking of putting a float in the next year's Rose Bowl parade. With so many ethnic and cultural assets within our own physician ranks, we regularly take advantage to learn from each other on how to deliver the best evidence-based care to culturally disparate populations. And that includes your patients who are LGBTQ, gender nonconforming, and those who have differences of sexual development. A recent publication of the American Association of Medical Schools tells us that an estimated 11 million Americans are LGBT. Anecdotally, I suspect that number is a lot higher. And that 1/2 to 1 million Americans are born with differences of sexual development. It's estimated that 56% of the LGB communities and fully 70% of the T community report experiencing some discrimination in seeking care, whether it's in our hospitals, our doctor's offices, or our emergency rooms. And those with sexual differentiation issues often receive excessive treatment, not undertreatment, because of provider bias or misinformation. So your LGBT patients are therefore at risk for poorer physical, mental, and behavioral health, and wind up showing higher incidence of depression, suicide, cardiovascular disease, obesity, addiction problems, and even some cases forms of cancer. 1 in 5 LGBT medical students, according to this report, admit to seeing discrimination against LGBT students, and they themselves have higher rates of emotional distress and social isolation. I guess that's what I talked about in the whole first half of this. So I don't believe that anyone ever really teaches anyone else anything. I think you all learn from inside. But I've got some principles here that I follow. Principle number 1, every cultural group, including the LGBT community, approaches healthcare with differing needs and expectations. And this goes beyond mere compatibility of language. So what? Know the community you serve. For example, I learned from some of my colleagues that, and because of where my hospital is located very close to the Fairfax district in Los Angeles, I have a very high incidence of very conservative Hasidic Jews, including, I have 12, it's my special minion, who still have the tattoos of their survival days in the concentration camp, and I take special care. So I learned from them that, for example, I go into a room, it's the wife of, it's the woman who's going to be my patient, but her Hasidic Jewish husband is there. I know now it's culturally acceptable and preferable for me to shake his hand and not hers, even though she's the patient. And there are other things I do with Arab patients. They never see the soles of my feet. I make sure never to touch anything significant like food with my left hand in their presence. Little cultural things. Right? May not seem important, but to violate these norms is noticed. Principle number 2, a gay like does not require like. A gay physician can treat straight patients, and straight physician can treat the entire LGBT community successfully. Number 3, patients remain sexual throughout their lives. I'm a urologist. Do I have stories? But I remember third-year rotation in Portland, Maine, going through OBGYN, where the gynecologist went up to the bedside of a woman in her 80s who was going to have surgery the next day. You don't need to know the details of the surgery, but it would involve, because she had already had a lot of surgery, she had some dissensus or prolapse. London Bridge is falling down in layman's terms. And she was going to have a cerclage procedure done, which, to be delicate, would have prevented her from engaging as the receptive partner in male-female intercourse. Are you with me? Her husband's standing next to her. She's 85. And over the next 20 seconds, because the physician is getting informed consent, right? And I saw the look pass over her. It progressed from, what did he just say? What did it mean? And then, oh my God. And what she said is, but doctor, I'm a married woman. Never forgot that. And then I saw the next 20 seconds, the physician. What did she just say? What did it mean? And oh my God. Number 4, learn to be comfortable speaking about sex and gender with all your patients. And some of you, depending where you come from, you might be a Mormon, you might be a fundamental Christian. Your parents may have had trouble with this. Your religion, you may have been personally traumatized as a child. Rape, molestation, you might have issues. But if you're going to be a successful doctor in this century, learn to be comfortable. Practice among yourselves the language part of it. Certain things haven't changed since 1980s. Be comfortable and learn more than the vocabulary. Learn the sensitivity. Make no assumptions. Don't be judgmental. Don't condescend. Use humor. Listen for the real story, because patients, when it comes to their sexual history, will not tell you the real story. Be aware if the sexual history is inconsistent or suspicious. I'm going to give you some examples. I was young once. I had a man who kept coming into me. I deal with erectile dysfunction, right? Okay, now it's on the news every day, but and he kept saying, I can't have sex with my wife, I can't have sex with my wife. And it was on the third visit, it turned out, but when I go to Vegas by myself, no problem. Okay? Listen for the real story. I had a young man, 42, extraordinarily well built, with no health problems at all, who said he was failing phosphodiesterase, the Viagras of the world, and wanted enhanced treatment. I'm really good. I can succeed in almost every male through various cocktails. If you're interested, I'll give you the recipe. So I gave him this. It involved an injection of a combination of prostaglandin E1, papaverine, and phentolamine. There's a test question for pharmacology, right? What do all they do? They vasodilate locally. But the problem was, 3 times he woke me up by presenting to the emergency room at 3 in the morning with priapism. And on the 3rd time, I get tired. I got to work the next day. And you don't want to know what I have to do to you to get priapism down, because that should only happen at Guantanamo and other bad places in this earth. But I said, something's not right here. You have no risk factors for ED. You demand this treatment, and you're presenting with a complication that's preventable. What's going on? And he admitted he's a porn star, and he needed. I live in LA, and he, he had no problem. But it's 10, 12 hours on the set. Workplace induced. I don't know. I wonder if he's a candidate for workman's comp. Listen to the real story. A 17-year-old African-American who lives in a really, really rough part of town comes in complaining of erectile dysfunction, and by history taking discover that he doesn't really have a problem when he's alone, but it's just when he's with girls. Okay? So being the gay man that I am, the light bulb went off. Right? And so I ask him, I say, what do you how do I put this? So you're having problems with girls? Yeah, he said, they're demanding and whatever, and I got this problem. I said, have you ever thought about having sex with boys? And his answer was, oh, I can't do that back where I live. What straight man would ever answer that question that way? Be attentive to the language. They're telling you the story, but because it's filtered through the matrix of sex and sexuality and gender, they can't just blurt it right out. But boy, once it's out on the table, then it's easy going. All right? So engender the trust that breaks down that barrier, and you'll be fine. Number 5, you're going to wonder how many of these there are. Getting a sexual history, you're going to find a lot of your patients, especially the elder ones, come in with the daughter, especially in my office, because they always bring in somebody to translate, even though I might not need it. And the sexual history you get when there's a son, daughter, granddaughter, or father, mother, whatever, is not the sexual history you're going to get when you ask them to leave the room. Families may love each other, but come on, okay? So remember that. Ask the same questions after, like when you're going to do the exam and everyone leaves the room, go back to that question. Principle number 6, learn a language. Heck, learn 7 languages, right? If you live and practice in an area, really, if you're going to go to northern Maine, come on, learn a little French, okay? Learning to say at least a few words in a language. If you've done it, you've seen the expression. the effect of saying hello, how are you, good morning, or maybe some little fun little anecdote. With my Latino patients, if it's before noon, I'll say, buenos dias. El que madruga come pechuga. He who wakes up in the morning. It's a pun. It's normally el que madruga, Dios le ayuda, right? Whoever gets up in the morning, God helps him. But the way I change it around is whoever gets up in the morning gets to eat the best breast of chicken at the kitchen table. And they laugh. And I do that in Tagalog. I don't speak these languages. Tagalog, Farsi, Armenian, Korean, and about 20, Russian, and Igbo, right? Because I have a lot of Nigerian patients. And I'm trying to master like Eritrean because I have a lot of people from the Horn of Africa. The face opens up, they smile, they laugh, the ice has been broken, and it's a wonderful introduction. Language is powerful that way too. Number 7, recognize that many people live in closets, not just LGBT members of the community. And this is something that LGBT people have, not maybe the ability, but maybe the obligation to help other people who are in closets find their way out. You might be ashamed of your body. You might be ashamed of some aspect of your habitus. You might be ashamed of your family. They might have been very, very poor. They might be of the wrong religion. You might have been convicted of a crime. You might have been raped. You might be undocumented. A physician can breed the trust where people will open up to them. Why? Why is that important? As some of the medical students yesterday said, why is that important? Well, because it will lead you to deliver more comprehensive and correct and better medical care. And that's really what you want to do. What we seek in the Permanente Medical Group when we look for physicians, I was thinking about this, is probably what you all might want to develop in yourself. We're looking for smart, innovative, board-certified physicians who are compassionate with their patients and capable of giving culturally competent care to widely diverse populations. We score our doctors on that. Evidence-based medicine. So whether you wind up in we're Jerusalem Corners, Vermont, there is such a place, or you wind up in a city of 10 million people, whether you're in a group practice, a single specialty group practice, or a multi-specialty, or a gigantic family like Permanente. I've got 5,000 partners. We're the largest single partnership in the entire world in Permanente. You're going to want to do that. The challenge is if you wind up outside Auburn, Maine, or somewhere deep in a really rural and you're alone, you will not be able to survive alone anymore by the time you finish your residency. You'll be forced by the economics of medicine to aggregate it somehow into groups. You may be the only person in your office, but you'll still have to have connectivity. So, I don't know. I don't know what you get out of this, having somebody talk about their history. It certainly is a delight to be here. And maybe it's a good time for remarks or comments. That's all I have. Thank you. You don't have to out yourself. You can just ask a question.
I have a question.
Hi.
Thank you so much for coming. I guess I was kind of wondering, like, what your children's experience was. I guess when you were sort of had to be closeted with the military, if they really knew that there was this big secret, or how do you explain that to them, or if you did or didn't. I was kind of curious about that.
The boys are very, very aware they have two dads. Yes. Right. Right now they think they have two Nazis for parents, but I think I I shielded them from the experience that they never had of. How do you not have the experience of not seeing your dad go off to war? They just didn't know. George had to deal with the fact that I was gone for 3 months, and with adopted children, we got them when they were 7 and 9. They will always have separation issues. So my leaving was a double whammy for them. When you have adopted children, you never have, as you might with your biological children that you've raised from birth, you never have a timeout where you send the kid to their room, right, and be separated from you. We have time in. Get your butt over here and sit right down next to me for the next 15 minutes. So, I don't know. We were very nervous about adopting kids because there's rumors and ignorance in the general community. We put them in a Catholic school in North Hollywood, close to where we live, because the school system has an absolute, no holds barred policy against bullying. So, not that they've ever once in 7 years reported any comment from classmates. And this is the salvation of the world, like you guys. George and I can sit back now and not do another thing and watch the progression of civil rights knock down the last barriers against gay marriage throughout California. Because every day another cohort of people turn 18 and they vote and they could give a hoot, right? It's just remarkable. It's remarkable to, that's why I'm a little nervous about telling stories, because some of you might be going, what's the big deal? What's the big deal? That's the history part. I don't know if I answered your question, but that's the best I can do. Okay, thanks. I wish the kids could be here, because I told everybody, George has seen snow 5 times in his life, and he never, ever saw it come down, and we had to drive from Albany to Burlington through what even I think was one of the most impressive snowstorms I've seen. So, yes?
Could you talk about how, as a physician, you go about learning about populations that are diverse from you? Is it something that you start with your colleagues?
Yeah.
Your community? How do you do it, and,
right.
and what resources do you use?
Right. We have a lot of resources. In fact, we have, every physician who joins Permanente Medical Group gets a stack of individual pamphlets. These are 20-page pamphlets on the special care. These are not condescending. These are evidence-based, highly polished, on the care, on the delivery of medical care to the Pacific Asian population, to the Latino population, to the conservative Jewish population, to the LGBTQ population. So there's that resource. And then we have grand rounds periodically where if one of our own physicians doesn't get up, we will invite somebody from the community. Sometimes a physician, sometimes it might be a rabbi. Sometimes it might be the abuela, the grandmother, because, in the Latino culture, there are certain, boy, if you've got a little Latino boy and he's brought in by, at least in LA, and brought in by his grandmother, you had better make sure that at some point you put your hand on that kid's head. He's younger than I am, I can do that. Little things like that. So it's not just the general philosophy. We get right down to the nitty gritty of, you really shouldn't do this. And, right? Who would never shake hand with their patient? It's difficult for me, I kind of nod. Hi, how are you? Yeah, that's how we do it. And we have the resources to do it. I don't know what you do. We can share these things. If you wind up in private practice and you want some of these things and you're all by yourself, yeah, ask me. I'll get you copies. Yeah.
I'll just say, I'm happy to see you again.
Thank you.
We haven't seen each other in 29 years, so it's great.
That's right.
But it'd be wonderful for us to have copies of those pamphlets for our doctoring skills.
Yeah.
Really?
Really. We'll be in touch.
I can make that happen. Yeah, right. Don't reinvent any wheels. I saw a hand over here. Yeah, yes.
How do you, again, Kaiser, how do you all go about institutionalizing these aspects of diversity and conversations around it, or when an issue flares up, how is that addressed?
Wait, I missed the first part of that.
So at Kaiser, how do you institutionalize the response response to any issues that might pop up around cultural sensitivities or something that might happen at position level. Does that make sense?
It does make sense. I'm not sure. I'm trying to think of an example. I'm not saying we're the best at it, we're the perfect, but I don't know of any. Well, I'll give you an example. I may have used this with a small group of students. I hate to be, but not too long ago, my nurse comes running back, distraught completely. She had just made a major faux pas. The consult read, patient with blood at tip of penis. Make assumptions, right? So she called Mr. Jones back in, only Mr. Jones didn't stand up. A woman in a dress stood up and she was not happy. That qualify as a good example? Okay, good. So nurse in tears because she knows this is shows our culture is working. She recognized that she made a big boo-boo, even though it wasn't willful, right? So I said, let me handle it. I brought Mrs. Jones, I brought the patient back into the exam room, sat her down, and I shared the distraught. And I said, my nurse is terribly sorry. I hope we didn't embarrass you. But let me start. How would you like to be addressed? And she said, Mrs. And I said, fine. And then I was kind of next step looking at the anatomy. She was wearing a dress that, you know, even to me, a gay male, I could tell those look like real breasts. They could be augmented. They could be pharmacological. It doesn't matter. And I said, as a urologist, I know why you're here. I need to know the anatomy. Can you describe your anatomy? And she said, yeah, the breasts are fine. I took all these chemicals and stuff like that. And I showed her the consult. I said, blood at tip of penis. And she said, yep. And she said, I didn't want to lose it. And I, at that point, kind of I was factoring, you know, like I was thinking. And at that point, 15 seconds go by, she just taps me on the knee and says, Doc, it's real easy. Think of it this way. The train leaves the station. People get off at every stop. And we laughed. The ice was broken. And from there on, it was, how do we go about doing a hematuria workup? And you know, we addressed the issue that, hey, by the way, you still have a prostate. We should talk about that too. Humor, well, in urology, we could not survive without it. But I think it's probably good for all of you. Yes. Hi.
Sorry, so just to piggyback on Justin's question, I had a similar kind of train of thought around, I guess, how to learn more broadly, like as an institution, like as a class, as a med student class, from some of the, you know, slip-ups or mistakes, or, you know, wanting to be sensitive but maybe using the wrong terms or faculty using slides. Like, how do we generate a discussion where we can grow as a community?
Right.
And learn from those?
I suspect that if you're talking about an older physician, you know, chances are a lapsus linguae, you know, a little slip of the tongue, it probably belies not any malice or hostility on his or her part, but rather a mindset that comes out of 1940, 50, 60 rather than today. Cut them a little slack. But somebody in your class should, can I spend 5 minutes with you? I'm really good at that. You know, can I, you know, let me just tell you how what you said, all best intentions, was perceived by at least some of the people in the audience. They will be mortified. They will be mortified, and you would have done them a big favor. It's not just that they won't repeat that one mistake, but it may get them to think about, how do I restructure my thinking on this, right, altogether. But it takes a little personal responsibility. And you don't have to be the offended party. You could be a friend of the offended party. Knock on the door. What have I not cut? Yes.
Thank you very much. And I thank you on behalf of the community, and you and I talked a little bit about my feelings about what you're doing for us through a generous gift. And I wondered if you just might tell us in a minute or so, for you and George, what it's meant to give this gift to our community.
What we would have what?
What it's meant to you.
Oh, besides getting him to experience a Vermont winter. No, it's wonder. I mean, you made me who I am. Yeah, it's quite clear. In spite of the personal difficulties of sitting 4 years here as a closeted class of one, the Greek word for class of one, by the way, is idiot. Idios, like an idiosyncratic class of one. I was the idiot in the class. But in spite of that, this institution made me who I am, extraordinarily happy, professionally fulfilled, able to have a wonderful personal and professional life, and reached quite a lot of I didn't, I was president, as an out gay man, a president of the of the California Urologic Association, going to be the president of the County Society. I'm a trustee of the California Medical Association, running for office with the support of Republicans as well as Democrats. It's really wonderful being out, at least in that environment. Could I pull that off in Salt Lake City, or I don't know. Maybe I should just stop right there with, but I don't know. But it really has been wonderful, and I got the technique to be successful from here, and I owe so much. To UVM. So you have to pay back. Yeah. Pay forward or pay back. I'm paying back. We're not wealthy, but and I promised to give the medical school some money when I die. And then the dean found out that all my grandparents lived to 100, and he got nervous. So, but this is a model that I might encourage other alumni to consider. Don't wait. Don't wait. Yes, sir.
You describe yourself as a positive gay, but you've made several sort of courageous transitions in your life, not just your sexuality, but you're from being a professor of music history to being a physician, from a pretty safe sort of life to truly volunteering to serve in the military. How do you how do you approach those transitions? How do you get up to them? How have you had that sort of courage to make really big changes in your life?
You have to be my psychologist, I think. Wow. Part of it, and I once again talked a little bit about this to medical students, gay men and women we're victims of a syndrome called the best little boy in the world syndrome. And in order to make your way in this world and insulate yourself as best you can against discrimination, discrimination that maybe a gay faculty member might be afraid of, if he's new to the faculty and doesn't know if I come out, will I get my grant approved, will I get tenure, things like that. All kinds of, will I get hired by the conviction that, I guess I'm trying to answer 4 questions at once. So you have to be really, really good at something. And I got really good at something. I got a doctorate in music. I was a professor of music. I had a Fulbright grant, but that wasn't enough. You have to be really good. So why not another doctorate? And yeah, sure, French is good, and Italian and German, but why not Arabic and Portuguese? And why stop there? So part of it is that we have to overachieve in order to succeed in life. And I don't know the other part. Always suspecting that I'm going to land on my feet, and the ability to win people over by my personality. And that has certainly turned out to be the case in my life. People who find out I'm gay after they've known me for a while, not a problem at all. Not a problem for them. So I don't know if I'm answering the question. That's a really personal question. I'm glad you asked it, but it's difficult for me to answer that. Ma'am?
Thank you so much for coming. I wonder if you could speak a little bit about your decision to run for office, and sort of what inspired that choice. I just think it's interesting when a physician sort of take that step. So. Yeah, the most difficult thing I ever did, including my years of residency. I'm very involved in organized medicine, and boy, would it be
be a walk in the park in Vermont where you can call your senator and get the governor to call back. California is much more difficult, but so many things need to be done. The legislature introduces 4,000 bills a year. Many of them impact our patients or our own medical practice. And so to advocate, we're trying to implement, Covered California is the Obamacare implementation in California, and there is no physician. The only medical expertise in the California government is a dentist and a optometrist. No offense, but they're passing laws on whether women under 30 should get mammograms and whether doctors should be mandated to take 10 hours of CME credit on teenage suicide risk in tricyclic users. Well, a great subject, but why should a urologist study that? So the effort to want to, when you're really good in the office and you look around and say, but whole communities need to be served, right? By putting your foot in the elective office, you have the opportunity to affect entire populations, right? We have a law that just passed in California that outlaws the sale of high fructose beverages in any school. That idea came from a medical student who was a delegate to the California Medical Association. So we take ideas like that, we hash it out, and then we find a willing legislator who will turn that into a bill and then lobby for its passage. So I encourage all of you to consider getting involved in your county and certainly your state, in this state, Vermont, your county medical. Think of being the AMA delegate, being a delegate to the AMA from your state as a student or as a resident or as a young physician. They have sections for all of those. So it was a desire to serve larger communities in California. If there's anything major I left out, yes. Hi.
I just want to say thank you for toughing it out through that don't ask, don't tell crap.
Yeah, that was hard. That was hard. But I really loved being a medical corps officer. I really did. There are a lot of soldiers out there. I get an Army Commendation Medal every time I save somebody's life, and I've got unfortunately, have quite a collection of them. In my last rotation in Iraq, the tent next to mine was blown up by a mortar, and a young 21-year-old airman was 10 feet away when a mortar hit. He lost both arms, one leg, and part of his manhood, and I kept him alive by direct transfusion of my own blood into him. There is no blood bank on the battlefield. That's why every soldier has his blood type written on every piece of clothing. So I, as the doctor, can say, O+, O negative. You, and doctors don't request in the military. Everything I say is an order. There's no compliance issues. Soldier, you will get that 5th anthrax vaccine in your triceps. I don't care if it hurts. Roll up your sleeve. So I order this soldier to give a pint of blood to that one. But so when you have that experience, how could you not? Thank you, though. I appreciate the compliment. Thanks very much. I appreciate you all being here. This was wonderful. And I hope that the modest gift that we've given the college will bring somebody even much more erudite and experienced than me to come back in the future to continue this, because it's an ongoing need. Maybe someday, 5, 10, 15, 20 years from now, there won't be a need for this lecture. They'll look back and go, when you come back 32 years from now, 2046, and standing up here talking about something in your life, you're going to look back and go, how quaint they had this LGBT lecture series. That would be wonderful. But it would be a success thanks to your efforts. Thank you. Thank you.